Welcome back to another episode of Single Payer Radio. Single Payer Radio is a project of Kentuckians for Single Payer Healthcare and Physicians for a National Health Plan, Kentucky. I'm Mark McKinley. I'm a volunteer with the group, and we're proud to be a partner with Forward Radio, WFMP 106.5. And with us, as we have been for about the past year, is Dr. Mike Flynn and Dr. Eugene Shively with their guest. So without further ado, let me just say the views and opinions expressed on Single Payer Radio are those of the speakers and not the station. So, Mike?
Yes, let me also make that same disclaimer that any comments that I make here do not in any way reflect the Department of Surgery or the University of Louisville. Gene, you want to do your disclaimer as well?
Yeah, any comments that I make are my own. They don't represent the Taylor Regional Hospital in Campbellsville, Kentucky, nor the Department of Surgery or the University of Louisville.
All right, well, our topic today is head and neck cancer and tobacco, and we're going to discuss these separately and together. And we are fortunate in that we have a guest expert to join us today, Jeff Bumpous. Jeff is, I guess, primarily a head and neck surgeon. I've known Jeff for years, back to the days when he was a medical student here. It was really scary. He is an otolaryngologist and a chairman of the Department of Otolaryngology at the University of Louisville. And Jeff, we are grateful that you're willing to spend some time with us and help us work our way through some of these issues. As we've done in the past with our Zoom guests, we generally give you an opportunity to make whatever comments you'd like to make about either tobacco, head and neck cancer, together or separately. And after you're finished with that, then we'll begin with the conversation.
Okay. First of all, I'd really like to thank Dr. Mike Flynn, Dr. Gene Shively. I've known both of you guys for a long time and appreciate your mentorship over the years and your friendship always. I am chair of the Department of Otolaryngology, and I guess my disclaimer too is these represent my views and not the views of the University of Louisville or the Department of Otolaryngology at the University of Louisville. That notwithstanding, head and neck cancer is still a big problem in Kentucky and a big problem with younger folks, and while we've seen a decline in smoking and tobacco-related malignancies really across the country, that decline has occurred at not as great a pace in Kentucky. And fearfully, with tobacco use and tobacco use taking on new forms, such as vaping and things like that, it's going to be a continued concern. I think the only other thing I would say in introduction, Mike, is that kind of on a collision course with that is we now have oropharyngeal cancer. So those are cancers of the tonsil and the base of tongue region that are related to human papillomavirus. And Kentucky is particularly a ground where we can see the collision of smoking or tobacco use and the papillomavirus related cancers. And we know that people who have a greater than 10 pack year smoking history, that's like 1 pack per day for 10 years, they don't fare as well, even if they do have a papillomavirus related cancer. So Kentucky kind of remains in the what I would call yellow zone to danger zone with regards to head and neck cancers.
Gene, you want to fire the first shot across Jeff's bow?
Okay. Well, what about the HPV vaccination? We hear a lot about that. I'm not sure how many people are getting it, but does it prevent head and neck cancer as it does cervical cancer? Can you hear me?
Gene, I think that's a great. Yeah, I can hear you. I think it's a real important point. And, virtually every state in the United States, New York was the first one who actually also insisted that the HPV vaccine be covered by insurance companies, even for boys and adolescents. The current kind of guidelines are for vaccination of individuals under 40 years of age. And there are even some special considerations for folks up to 50 years of age. About 80% of tonsil and invasive tongue cancers now are HPV related. And it's the type 6 and type 18 of that virus that tends to form the cancers. This is also a virus that is related to cervical cancer and anal cancer. So it's, it's certainly a disease. In this year of a pandemic, we really are recognizing the importance of vaccinations and viral disease in human beings. But this is a highly preventable cancer if we get our children and adolescents vaccinated.
How are we doing in the state of Kentucky with vaccinating our children and adolescents and adults?
Well, it might not be a surprise to you. We do a pretty good job in urban centers and in places that have, where people have good access. If you look at areas, more disenfranchised areas like the West End of Louisville, and look at rural communities, they may not have gotten as much information, nor may they have had as much access. I think it really depends a lot on an active physician community to kind of get that word out. Kentucky Cancer Program, as well as American Cancer Society, have really tried to get that message across and to get the vaccine message across in a big way. But the larger cities tend to fare better with regards to this than rural communities and poorer communities.
Can you also comment what role alcohol plays in head and neck cancer?
Yeah, alcohol is probably a weak carcinogen by itself, but it is a co-carcinogen. So people who use tobacco products and alcohol together, it really creates a perfect storm. In some ways, alcohol strips the mucus off of the mucous membranes, and that probably allows the tobacco's carcinogens to have greater contact with the tissues. It also can increase the solubility of some of the things like the aromatic hydrocarbons that are in tobacco. So it really facilitates the cancer. It probably in and of itself, although it has its other health risks, doesn't cause the cancer by itself, but it certainly makes tobacco a much more potent carcinogen.
Jeff, let's drop
Go
back,
ahead.
do some basics here. Majority of our listeners don't have a medical background, and when we talk about head and neck cancer, there's a lot of different places where you can have cancer and some different types of cancer. So could you kind of set the table in the beginning so that we have a sense,
Sure.
So the listeners have a sense of, when you talk about head and neck cancer, what are some of the different possibilities, and what ones are somewhat more common than others?
Sure. For the most part, the ones we're thinking about, the most part, are cancers that can exist of the mouth and the tongue and all those parts. And then on further down, obviously the throat. So the voice box and the upper swallowing parts of the throat. Common areas that we see with these tobacco-related cancers in Kentucky are mouth cancers that occur on the tongue and floor of the mouth, and then also cancers of the voice box and larynx. For those using smokeless tobacco, obviously the oral cavity cancers. So the people who dip, snuff, and chew tobacco getting cancers on their gums, or getting cancers in the floor of the mouth where the plug of tobacco is sitting, are the areas that are at highest risk. And then other kind of less common cancers, but cancers of concerns that we see as head and neck cancer surgeons, are skin cancers that occur in the head and neck, and then thyroid cancers, which are obviously arise out of our thyroid gland.
I remember when I was a medical student being impressed with how much anatomy is packed into the head and neck, which represents about 10% of the body mass. there's a ton of anatomy, both physical anatomy and functional anatomy. I mean, and there's a lot of places where you can get cancer. You mentioned vaping a bit earlier. I was kind of curious. This is in the same sort of vein as some of Gene's questions, but what's the mechanism of vaping as opposed to because that's not a tobacco product, is it? Or unless I'm
It doesn't have to be. So
Yeah.
that's why it's really a mixed bag. Some of these are just, if you will, herbal kind of mixtures and things like that. So not all of them contain tobacco, although some do. Some contain nicotine and some don't. So, really understanding the role of it is hard to know. But the one thing that has been a concern about it is with some of the formulations, there are high doses of nicotine. And the second thing is there can be high doses of these aromatic hydrocarbons in some of these vaping solutions. So although we don't have a long-term amount of history with them, like we do cigarettes and chewing tobacco and things like that, there's certainly substances in some of these commonly vaped concoctions that are not good, that kind of replicate what happens with smoking.
All right, then how about marijuana? Before we got started here, Mark and I were talking about going out to Colorado, and it's legal in Colorado. You can,
Sure.
you can go down to, we've got a place out in Crested Butte. There's a little green store down on the main drag where you can go in. They check your license, and I guess they put you on some sort of database, and then they let you in the door, and you can chew it, you can smoke it, you can eat it, and you can get some to put on your skin. So what's the relationship between cancer, head and neck cancer, lung cancer, and weed?
Well, that's a much more mixed story. So, and it probably has a little bit more to do with delivery. If you're smoking things, and particularly if they're in paper carriers, those paper carriers can also have chemicals, preservatives, and hydrocarbons. Marijuana itself is kind of, there are proponents on both sides of that equation. There are folks who say that it actually has some cancer preventative principles. There are those who say it could cause cancer. The only thing that I would say that's interesting in the medical literature is that marijuana use, particularly marijuana smoking, there were some studies that were done by really a pretty sharp late virologist who's at Johns Hopkins. She had been at Ohio State, named Maura Gillison. And Dr. Gillison demonstrated that HPV cancers were higher, or the potential of having HPV cancers were higher in people who were heavy marijuana users. Now, you kind of go back and look at that paper and say, what is a heavy marijuana user? And they were talking about someone who was, smoking 3 joints or marijuana cigarettes kind of a day, or greater as kind of the heavy user sort of thing. With the edibles and skin topical preparations, and with CBD oil and all the variety of other things that are out there now, there's certainly not as strong an association there. So, I would say it's a mixed bag right now. No pun intended.
Yeah. Gene, you want to have another one?
Well, I don't know if I can beat that one. When I was a resident, we didn't have an ENT program, so the general surgery residents ended up doing a lot of the head and neck cases, and I ended up doing a lot because some of the residents were interested in doing it. But one of the things I think we need to emphasize is how horrible some of these cases are. Just the disability, the surgery, and combine it with radiation and chemo. Can you discuss just some of the problems these patients have, and really how miserable they can be?
No, you're absolutely right, Gene. And I think Mike alluded to it a little bit. There's always a lot going on in the head and neck. It's kind of the conduit between the brain and the rest of the body. So it's how we we're recognized by our face and our voice. We kind of interact with each other by being able to use a voice or hear. We sustain ourselves by eating by mouth for the most part, although that can be bypassed, obviously. But you're right. Only they build me, and then we really treat by big or microwave instructions, and even by improved radiation or creating combined therapy with radiation and chemotherapy. One of the big things that I see, having practiced almost going on 30 years now, is the patients that are survivors that I continue to see are the late effects of treatment. You're right, especially late cancers and the treatment of the people.
Jeff, we seem to be losing part
they can oftentimes become reclusive because they don't feel comfortable. Yes. Can you hear me now?
Well, we were having some technical problems.
Are you there, guys?
For a while, yeah.
Yes.
I think that's better now.
Is it a little better?
Yeah.
Yes,
I'm
so
so sorry.
We've lost you again.
We would see a lot of the late effects of these cancers, and although we're better at restoring, any better?
Yeah,
yes.
That seems to be better. Yeah, we lost you for a while there, and your image is frozen up, and we were only getting snippets of what you were saying.
Mike, can you hear me now?
Yeah, I can.
With the effects of their cancer and or the treatment of their cancer for a lifetime. So it can be a very devastating cancer.
Well, as you and I both know, when I started doing head and neck surgery, which was way shortly after the assassination of Lincoln, we were doing this thing called the commando procedure, which was a terribly destructive undertaking with a tracheostomy and some face flap and a resection of the ascending ramus of the mandible and the tonsil, and then I think you used to do your own flaps. I'd have somebody like some of the plastic folks come in and do some reconstruction, right. And then these people got radiation, and they had all kinds of complications. They spent weeks in the hospital, and they had a 25% cure rate. So chemo radiation has changed a lot of that.
Yes.
Where does the sort of radical head and neck surgery fit into today's equation, where most of these people that we used to operate on now are being treated in a non-surgical way, initially anyway?
Well, yeah, I think, not to be over technical about it, I think oral cavity cancers are still treated quite often surgically, but obviously our reconstructive methods are improving and continue to improve almost on a monthly to yearly basis. But concomitant chemotherapy, or the use of chemotherapy plus radiation therapy, we're doing it a lot more. And particularly for cancers of the voice box and cancers of the tonsil and base of tongue. And that's because we can preserve function and preserve swallowing in those folks. But it's not without effort, and it doesn't occur in every patient. So to say that it's a panacea and that we're perfect, it's far from that. But you're right, we really perform less mutilating surgery than we did in the past. And I think that we also, when we do have to perform surgery, for example, if chemotherapy and radiation therapy did not work, we do have better reconstructive methods for putting people back together. But, the consequence of having a few more people survive from these cancers is we then have to kind of deal with the late effects or how damaged some of them are after the treatment. And that remains a challenge.
Now, I was impressed when one of your colleagues, Kevin Potts, came to a meeting that that Nora Brzezinski and I used to run for the Kentucky Dental Association, and he showed us a video of a robotic tonsillectomy, which was,
Yes.
just compared to the awful activities of doing a commando procedure. I mean, that was an elegant operation. And another example of that was a nerve-sparing prostatectomy that I'd seen a videotape of as well. So explain a little bit of that to our listeners, again, who are not mostly
Sure.
clinical, and how this really is an elegant way to deal with some of these difficult issues that, and seems to me, has a fraction of the morbidity of doing those bigger operations.
Right. And you're exactly right, Mike. We're increasingly doing robotic surgery, particularly for tonsil and select base of tongue cancers. And the advantage of the robot is that we can do a large surgery internally without doing the things we had to do in the past, like split the mandible in half and kind of open the face like a book.
Yeah.
We had to do those procedures because that was the way we had to cut through a lot of normal tissue to actually tumor. So the robot allows us to go through the mouth and arrive at the tumor and the target and adequately visualize and manage it. So it's been a real important thing. Like everything, it's not for every tumor or every patient, but for appropriately selected patients, it really does decrease the morbidity, and it allows people to have better speech and swallowing function and to maintain their appearance. So I do think it's an advance that's here to stay. And we're actually, interestingly, we're moving even to what are called single port technologies. So what that'll mean is we'll be able to use the robot further down the throat, and it's even a smaller robot than we have currently. So the technology continues to improve. So I think we'll see more and more of this in probably all kinds of cancer resections going forward.
Well, like further down the throat, where?
Well, like all the way to the vocal cord. So,
okay,
basically the FDA, the current robotics in the head and neck are limited to the base of tongue and tonsil. That's what the FDA has approved the technology for. But this will allow you to go even into the trachea. So these single port technologies are really pretty impressive.
Oh, that's great. Gene, you want to fire another round?
Yeah, when I went into practice, I was fortunate that Dr. Jim Ewing and then later his son were practicing in Campbellsville. So we continued to do a lot of head and neck surgery. Dr. Ewing trained in Tampa, and they really did a lot of surgery down there. So I've been involved in this for quite a long time. And one of the things that really impressed me was that we had a lot of patients, particularly after they'd had radiation, to get esophageal strictures. And I spent a lot of time having to dilate those patients, and of course the complications of dilatation and poor nutrition, having to put in G-tubes, etc.
Right.
And then of course the patients with permanent tracheostomies, and what's still amazing to me is the patients who smoke through their trach.
Yes. It says something about the power of addiction to tobacco.
Correct. Do y'all still see a lot of strictures of the esophagus?
Yeah, there are two things, Gene. I think I have, like you, and I'm sure Mike too, done a lot of esophageal dilations over the years for people who've had radiation, and we still see them. I think we see them a little bit to a lesser degree with the use of newer radiation techniques, but that hasn't made them go away entirely. The other thing that we've kind of discovered is that radiation, and particularly the type of chemotherapy that's been used for this, can also affect the upper esophageal sphincter muscle. So sometimes what we're doing is injecting that with Botox in addition to dilating the esophagus, and that seems to help some folks that have required frequent dilations or haven't been gotten as well as they thought they would with the dilation alone. So over the last 4 to 5 years, I would say that's something that's emerged and may be actually helpful for some of those folks.
Jeff, where does immunotherapy fit into all this? I stayed on the IRB after retiring, and one of the things we've been noticing over the last couple of years is a lot of studies with this targeted therapy, where you have a specific monoclonal antibody, and then combine that with a chemotherapy agent, and that targets the specific tumor. And then with the monoclonal antibody binding into the antigen, then the chemotherapy agent comes in, gets in. It's a very impressive, and kills the cell. And there was another study I looked at in which they combined the monoclonal antibody with a radioisotope, so that once the monoclonal antibody bind on the cell, then the radioisotope sneaks in and kills the cell. I haven't really seen any studies dealing with head and neck cancers. Is that
Right?
I guess it's, either we're missing them, or maybe it's just not a good option.
Well, there are some out there. So the first one, and the only really FDA approved one that is out there right now in terms of targeted therapies, is cetuximab, which is a monoclonal antibody against the epidermal growth factor receptor. And interestingly, that can be used primarily in treatment to help sensitize some cancers to radiation therapy. So we do that some, especially in people who can't tolerate the traditional chemotherapy, which can be very difficult on the kidneys and other organs. The thing that I think, there are two things that are pretty exciting, though. One that's becoming more into the mainstream, and one that's still experimental, but that we're fortunate enough to be involved with at the Brown Cancer Center. So the one that's in the mainstream and is actually performing better in recurrent cancers than the old traditional chemotherapy, cisplatin, is basically something called the immunotherapy. And the types of drugs are called PD-1 or PD-L1 inhibitors. And these are drugs that help really ramp up your immune system, particularly your T lymphocytes. It ramps up your T lymphocytes to really kind of make them angry against the cancer. And surprisingly, if you took somebody who had a recurrent head and neck cancer after treatment, there really wasn't too much we could do for those folks. They didn't do well. They still haven't done well. But classic chemotherapy would give about a 12 to 15% response. And in some of these cases, the drug actually gives about a 30% rate of patients that respond. So that drug got people's attention, and it's being used as a palliative treatment right now. So not a curative treatment, but I can tell you there are a lot of studies underway looking at that class of drugs to see where it could fit in earlier in the treatment of head and neck cancer. The other one is something called TILS therapy, which is tumor-induced lymphocyte therapy. And that's where we actually remove people's T lymphocytes, and we actually have parts of their cancer. And in the laboratory, we train their T lymphocytes to fight that cancer better. It's kind of like going to T lymphocyte boot camp in a surgeon's perspective. And then put those lymphocytes back in the patient to where they may be a little bit more in gear, a little bit better trained to approach that cancer and get to that cancer. So, I can tell you there's mind-boggling amount of things going on looking at approaches to these cancers.
Yeah, I think I've seen a couple of those studies that dealt with lymphomas. I don't know that I've seen any that are specific for head and neck cancers. Gene?
Well, one of the things I wanted to bring up was secondary primaries. People with head and neck cancers often develop cancer somewhere else. Can you discuss that a little bit?
Yeah, I think that's a huge problem, Gene, as you're well aware. Particularly the people who have developed head and neck cancers related to smoking and drinking, and maybe to some degree with this papillomavirus as well. There are multiple areas in the mouth and throat that could have been affected by those carcinogens. So we may be very successful in treating the first cancer that presents, but anywhere from 12 to 20% of these patients, depending on kind of where their cancer was originally, may go on to form other head and neck cancers or lung cancers. So we have to keep these folks under surveillance and kind of watch them. The group that's at the highest risk for these second primary tumors are the people who continue to smoke and use alcohol, though.
And most of these cancers originate in the lung.
The vast majority of the second primaries are lung cancers. The esophagus and other head and neck sites follow kind of as distant seconds.
Well, let's change horses a little bit and sort of kind of go back to the future and talk and get your views about these the effectiveness of tobacco cessation or tobacco quitting programs. There's seems to me that the best way to cut down on people's use of tobacco is to make it more expensive. But aside from that, there's counseling and medications. So can you kind of give us a sense of your thoughts about how, which one works the best, or where would you put them in in this area of how, because if you can improve somebody's long-term survival, they reduce the risk of a second primary by not getting them to smoke. How well does that work?
Well, I think there are definitely programs that have shown effectiveness, both with behavioral therapy and with medications, including things like nicotine patches or any drugs that can be helpful. One of the keys to this, though, is having the time to do it, opportunity for patients. So, more and more, I serve as the chair of the cancer committee for Brown Cancer Center, and the American College of Surgeons and ACOS have promoted survivorship in patients. And part of this survivorship is to make sure cancer centers and major health systems are trying to provide preventative services for patients. And I think this is a preventative service. This is just like vaccinating yourself against polio or something like that. We have to have dedicated professionals that can spend time with these folks. One of the things, I guess, is kind of a bizarre lesson learned from the pandemic, though, is that a lot of Americans, rural or otherwise, are connected by the internet, if by nothing else, as their iPhone. So using telehealth technologies to kind of help with this counseling and kind of keeping people accountable, checking in on them, making sure they're not smoking and kind of helping them through the issue and making sure they're compliant with any medications. I think that will be helpful. So I think that the pandemic and the use of telehealth has taught us something. I'm hopeful that that'll get more people on board with this. My personal experience, Mike, I have to say, has been far more disappointing than I'd like to admit. I would say that I've had probably about fewer than 10% of people stop smoking when I try to really emphasize how important it is. But I think how you do it, the amount of time we spend doing it, and the resources for patients are what's going to lead to success here.
Well, let me make what I would probably consider a somewhat off the wall comment, and let me see if this is something you've had an experience with. You remember Rob Campbell? Rob.
Oh yeah.
Yeah. Rob is up and he's a director of a small psychiatric hospital focusing on addiction up in Columbus, Ohio. And he was on a month or so ago, and he made the connection, it's kind of a 3-part connection between addiction, mental illness, and smoking. And, basically he said almost most of the addicts that they deal with have got some degree, some mental illness. And he said he's hardly ever seen one that didn't smoke. Now, this is probably not a fair question for you as a head and neck surgeon, but is this something you had any kind of observation or comments about that as an issue in dealing with patients with head and neck cancer?
Well, I really do. And I think, adequate access to mental health care is probably important. People, I don't know if they gravitate towards tobacco or tobacco and alcohol to treat underlying situations, but it seems like there's probably a truism there, Mike. And we do know certain populations, for example, bipolar patients have an increased incidence of head and neck cancer, and people with serious bipolar disease, a good many of them smoke and drink. I do think there's a connection there, and trying to kind of stave that off by making sure people are able to get their mental health needs met is part of this.
Gene?
Well, my experience in getting people to stop smoking has been dismal. I've been very disappointed. I made a lot of people mad, but I don't think I've gotten too many people off cigarettes. Maybe my approach has been wrong. In rural Kentucky, particularly when the family farm was dependent upon tobacco, that was just part of our culture. And everybody smoked, and everybody started smoking when they were in high school, particularly the males, but females caught up with them, with the males. And it seems like it's very difficult to reverse that. When I first started in practice, school in August and September didn't start until you had your tobacco cut and hung up. And then they would get down to studying other things.
Well, I think the best way to cut down on tobacco use is to make it so expensive that it really does take a bite out of somebody when they do a lot of it. So, Jeff, let's again switch horses a bit here and talk about the access to care and health coverage. As you know, we're one of the reasons we're doing this is we've got some thoughts about what kind of healthcare coverage we should have in this country compared to the 35 other first world countries that have some sort of universal health care. I stopped being a head and neck surgeon about 10 years before I retired, and they turned into an endocrine surgeon, which is an easier thing for older surgeons to do. So where does the for-profit health insurance or the private health insurance, the Medicare and the Medicaid and the uninsured, what kind of a mix are you seeing today in the patients that walk in the door with head and neck cancer?
Well, I see a mixture of both. In tongue in cheek, we used to say this was a cancer that occurred in people who were in smoky boardrooms and also people who lived under the bridge. Now that sounds very pejorative, and I surely don't mean it that way. But honestly, tobacco-related malignancies touch just about all society. And, one of the things that I've always felt fortunate being able to be at practice in the University of Louisville is I really didn't have to look too much to see where these people came from or how they were insured. I prefer to practice a medicine where I can see all the patients I want to. And I think people who, like Gene Shively down in Campbellsville, he's done the same thing, and whether people liked it very much or not. But you're right, Mike. I mean, I think that the thing that we have to do better is provide people appropriate education, early access to treatment and care, and then these preventative services. If you think about that, we've talked about HPV, smoking, and alcohol. This is the cancers that I see every day that are advanced. Virtually all of them probably could have been prevented. And that's the sad part of this story. Our concentration on preventative care in a meaningful way. Those other developed westernized countries with single payer systems that you talk about, boy, they've done an incredibly effective job of doing that. We always seem to say that, well, we're too heterogeneous and too complex in the United States. But the fact is that treating cancers that are delayed and late is incredibly expensive, not only in monetary terms, but in human terms. And I think that, we can still do a better job at the front end of this to try to prevent more of these types of cancers.
Now, I don't know if you remember, there was a surgeon in Louisville for many years, a general surgeon who ran for state office and became in the state legislature. I can't remember if which house he was in. I think Gene Tobit. But anyhow, he came to the Louisville Surgical Society. This is probably 10 years ago, maybe longer, and gave a really good talk about all the issues dealing with politicians and making policy. And he just straight out said that the politicians don't understand healthcare. They're led around by lobbyists. And that's one of the reasons this country is in such a mess. So, dealing with that issue is really going to be a challenge, because the for-profit health insurance companies have got huge amounts of money, and then they have a huge financial interest in maintaining the status quo. So, having said that, let me push you again into a bit of a corner. If you look at where we are today, we've got a new administration. They are proposing to do some improvements on the Affordable Care Act, a public option. As a group, I think we feel that Medicare for all would be a much better option for the country. I think realistically, both Gene and I feel that as much as this would ideologically be the best thing to do, from a reality standpoint, that ain't something that's going to happen anytime soon. And it took Japan almost 10 years to evolve from a system like ours to the universal healthcare system they've got today. So, just without getting you into a political place you don't want to be, any thoughts about the public option versus Medicare for all, and the likelihood of one or either of these getting done anytime soon?
Well, I agree. I feel like we've been talking about it for so long. When I was back at Paducah Tillman High School in the late 70s, I was on the debate team, and we were in the national debate topic of the year that I was a senior in high school was nationalized health care. And that kind of streams back to the Carter administration, et cetera. So, obviously we've been talking about the inadequacies we have. The sad point in this, though, Mike, is that if we have access to all, I believe my own, again, these are my personal convictions. If we develop a better access system, whether it's through expansion of Obamacare or Medicare in a rational way, that's going to cost the country less, and it's going to improve the quality of life of Americans. Half of our problem has been, who can see somebody, who will see somebody, who won't see somebody, who's incentivized to see somebody. So it's created this wonky imbalance in American healthcare. So I do agree with you there. And you have people kind of get down to, is healthcare a right or not? I think in a modern society, yeah, it is, and that's kind of my opinion, in a country as great and as wealthy and as successful, and quite frankly, even though we've kind of gone through really trials and tribulations in this last year, we ought to be able to do that. We ought to be able to accomplish that. And I think countries like Japan, Great Britain, Canada, although their transitions haven't been perfect, one of the things they've done is they've tried to make data-driven decisions, and they're not caught up so much in special interests, not caught up so much in emotional arguments. So they've tried to make healthcare decisions that are based on that. Now, sometimes they get criticized for being callous, but ultimately at the end of the day, if you look at health outcomes in those countries, they're far better than our health outcomes. And the bang they get for their buck out of a health dollar is far better than what we've been getting in the United States. So, we can't sit on our laurels and say that we've got something that's working well. I mean, I think we have a lot of technology. We have a lot of advance. We have a lot of study. We know about the sophistication of American medicine, but are we successfully applying what we have across our population? I think we're coming short there.
Well, back in about a year or so ago, when I showed up at the downtown library to go to one of these Kentucky single payer meetings, and I saw Gene Shively wandering around in the ground floor of the library. He took us up. He's got some really good data about the economic benefits of doing something like this, as opposed to the way it is today. So that there's a whole lot of money. Gene, you want to comment on this? That's available. Just the money that's in healthcare that's not being used to provide healthcare.
Well, we spend about 18% of our GNP on healthcare. That's about $3.6 trillion, and about 1.2 trillion. These are obviously gross estimates. That is wasted, and by wasted I mean we're the only country in the world that advertises. We've got a huge expense in administrative charges. We spend a huge amount of money in defensive medicine. We waste a lot of money in for-profit insurance, and it goes on and on and on. And so we can do better, and we can do better even regardless of the system we choose to adopt in the future, because we can save about a third of the amount of money. The problem is there are a lot of people getting very wealthy on sick folks, and people other than doctors and nurses, and so we can do it. We've just got to have the will to do it. Let me ask you one other question. Has Medicaid expansion affected the ENT program at the University of Louisville?
Well, I think what I would say with that, Gene, is it's just been a moving target. We went into Medicaid expansion, and then kind of that got halted, and now we're back at it to some degree. One of the things that the problems, I love the idea of expanded access. I think that's great, getting people to be able to choose their doctor, get in to see their doctor, and get earlier health care. That's a laudable thing. The thing about it that is troublesome, though, is that they all tend to be contracted or run by various healthcare entities throughout the community, and there are different rules and regulations for every Medicaid patient. So the administrative complexities, complications, and difficulties have magnified. Because you're not really dealing with one Medicaid, you're dealing with 12 Medicaids or 13 Medicaids, depending on how many are approved in any given state. So that's where the problem goes when you take a governmental program and kind of outsource it to a private interest. If you don't establish at least standardization and ground rules. And so we no longer have one Medicaid system, we have about 12 or 13.
That can make it extremely difficult by hiring extra people to stay on the phone all day long, getting pre-authorization and getting tests ordered and getting surgery and procedures ordered. How much of your office's time is wasted on that?
It is a lot more than I would ever anticipate, and even physician time. And you and Mike will recall, there was a point in time where it seemed like the doctor was having to get on the phone a lot for pre-authorization, in which they would have to talk with an expert about their care or their operation on a given individual. And then that went away. We did a bunch of that kind of in the early 80s and mid 80s, and then that went away for a while. Well, it's back again. So there are a lot of administrative hoops that we have to go through, kind of justifying our healthcare, even though everything is kind of well apportioned. Most of it's in an electronic medical record. And there are, and frankly, the problem is we don't always understand what the ground rules for reviewing a case or not reviewing a case are. I think most physicians are pretty smart folks. So if they knew what was coming down the pike, if they knew what was, what companies were interested in reviewing, we'd probably get that job done at the front side and they would never have to talk with us. So, the moving target with all this pre-authorization is what becomes difficult too. But you're right. I think that's an enormous waste. I can tell you anecdotally, over the time I've practiced, every time I've had to go in to do a pre-authorization for a patient of mine on a case or on an imaging study or anything else, it's always been approved. Now, that's generally meant me sitting on the phone, not seeing patients, not doing anything really productive for anywhere from 30 minutes to an hour, just waiting to talk to somebody. And there's never been a case where they've denied it. They've virtually, after having talked with the physician, approved it 100% of the time. So it makes you wonder, what's the value of all this, all the machinations that we're going through. And like you said, there seems to me to be inherent expense and waste there.
Jeff, go ahead.
How much time does your electronic medical records waste?
Oh boy, I've had a love-hate relationship with it, Gene. I think in some ways, I don't think EMRs are inherently evil. I think they can be designed to work well. My kind of learning curve is how to continue to foster a good doctor-patient relationship. Actually, spend my time talking to my patient and spend my time with my patient rather than clicking on a mouse or looking at a computer screen. So, I think the biggest downside and sad side of the EMR is that it has been a challenge to having an appropriate and good doctor-patient relationship. And as you're aware, there may not be much more that we do that's important. You've lived in a rural community where those people trust you because they know if they walked in your office, you were going to sit down and listen to them for a while, and you're going to talk to them and you're going to try to help solve their problem. And you probably understood a lot about them before they even walked through the door. But the EMR, it does put pressure on physicians. We need to make it better, and we need to make sure whatever form it takes doesn't take away from the doctor-patient relationship.
Jeff, I don't know if you remember Ted Young. Ted was the president of the Society of Head and Neck Surgeons the year before me. And after a couple of years, it amalgamated with the American Society and then became the American Head and Neck Society. We had Ted on probably back in the spring, and we talked about some of these issues, pre-authorizations of an imaging study and the issue of billing and it's so much easier to practice in Canada under their current system. He had one person in his office doing the billing, and they sent the bill to one place, the government, and then 2 or 3 weeks later you got the money. Whereas in this country, you've got 1,000 for-profit insurance companies plus Medicare and Medicaid. Each one of these insurance companies have got 25 or 30 plans. It's insane. And you have to go through all these administrative hoops to try to get paid, and then you don't get paid for 6 or 8 weeks anyway. So there's a whole lot of very basic financial and administrative and functional reasons to improve the system. We're getting down to the end of the lollipop here. I just want to let you know, I think we've got about four, according to Mark, we got 3 minutes. We've got 3 minutes left. You were doing some screening things down at the state fair. I guess before all the pandemics. We know that the incidence and the death rates from breast cancers decreasing, probably largely because of the availability of screening mammography, and similarly with colon cancer, either doing colonoscopies or doing the Cologuard thing that was recognizing the DNA and what kind of activities are going on, again, getting short to the end of the lollipop here, from a screening standpoint, either at the state fair or any other places around Louisville or Kentucky?
Well, the thing we've done at the state fair, I've been proud of, is part of Oral Cancer Awareness Week, and this was actually you'd be proud of it too, Mike. Is the Head and Neck Society, which is now American Head and Neck Society, that combined society you were talking about when, as I recall, you were president and Charlie Cummings were president to get those two groups together. But they do an Oral Cancer Awareness Week that supports the ability to do screenings of the oral cavity, particularly in smokers across the country and even internationally. They're even offering grants to help do that in disenfranchised communities, or communities that may not have the ability to have as much access. So, I think it is important, not only just kind of looking in folks' mouths and things like that, but also getting the word out about tobacco addiction and options of kind of getting off of it, and getting the information out there that communities need about HPV and things like that. So when we have those events, it allows us to do some education too, which might be actually more important than the screening in some ways.
Well, Jeff, listen, I just want to thank you. This has been very informative. We've had a good time talking with you. We're at the end of the road. I hope we didn't take up too much of your time in the middle of the day. But thanks again. It's great.
Not at all. Not Mike. Mike and Gene. It's my pleasure. I've enjoyed your friendship for years and respect you greatly. And I think what you're doing is a great thing.
Thank you very much for being here.
Okay. You guys have a great day.
Okay.
Bye-bye.
Bye.
Good deal. Thank you. And for folks who want to learn more about single payer radio and Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org, kyhealthcare.org, and to contact our chairperson, Kay Tillo, you can go to nursenpo@aol.com. That's nursenpo@aol.com. Kay can share with you how you can get involved with the group and learn more about the movement. Mike, Gene, thanks again. Y'all have a happy Valentine's Day now.
Well, you do the same.
Bye.